While they're loading my slides, thank you for having me here. I don't think I could have been a vitreoretinal surgeon if I didn't know buckles. And it's a great technique. I'm thankful to my teacher, Dr. Das, and Professor Amod Gupta, who taught me buckling. In fact, in PGI, I spent 3 months extra just to learn buckles. So that was at the end of my residency.
Can you show the slides, please?
So if we talk about skill buckling in the era of vitrectomy, I think both are there side by side. To my mind, there's nothing like era of vitrectomy. Can we have the slides, please? Okay. So I just go back 30 years when I published this paper along with Dr. Das, and you can see here that case number 4. Even today, after 30 years, the only surgery I would do would be a small buckle for 20 minutes and not go in and create, multiple surgeries and do all those things. And this I can do in a non-retina theater, so I don't need 3D systems to do that. And so what I want to highlight is, I'm going to show you just few cases where the buckle scores over vitrectomy. This Stickler syndrome patient, left eye, underwent vitrectomy in my hands 20 years ago. And over a period of time, vision dropped from 20/40 to count a finger because of the band keratopathy, because of progressive glaucoma, and now he's almost blind. Where the right eye, with the reg RD, we put a buckle, and that's it. Even if he doesn't come for follow-up, I'm very pretty sure that his 20/60 vision is going to be there for lifetime. Old chronic RDs, again, if we try to do surgeries in these patients, the vitreous is bad. The subretinal band removal requires a lot of maneuvering. There'll be hemorrhage, and then all those things. So you just put a buckle, and the retina will reattach. And this patient has 636 vision for life. I would not be able to manage all these cases of ROP, FEVR, tractional detachments if I didn't have a buckle. So these children, we are putting a belt buckle. You can see the retina flattens and the fold also opens up, and for whole life, they are fine. This was very exciting. I did a buckle along with some imbrication in 2 quadrants, and you can see here this child from Bangladesh. I didn't have to do a lensectomy, vitrectomy, try to open that fold and create a unilateral aphakia. A single 240 band with imbrication opened the fold, and the whole ROPs, become stable. In retinoschisis, in selected cases, if we can do a buckle, there's nothing like that. These are young patients. The surgery is very difficult. The planes are not very clear. But in a patient like this, where you see even the RD can be missed. The center has RD, the side has RD, and a buckle will cure for life. Somebody is using the phone. Please switch it off. इनको बोलिए प्लीज़ फ़ोन बंद करने के लिए. If you have subretinal bands which are not tenting up the retina, then this patient had a buckle, and after a few years he had buccal exposure. We removed the buckle. Nothing is happening. He is very happy with whatever vision he has. Even if we do a vitrectomy, that macular change is not going to help him. The imbrication technique, which I have now done very well, along with the buckle, adds to the value, as you can see in these very complicated detachments. So it's not that buckle is used only for simple detachments, but for very complicated detachments where you would be lost trying to remove the vitreous and try to put oil. You will never get what you can get with a single buckle along with the imbrication. Where would you land in this patient? You don't know where the vitreous is, what you're trying to remove. The retina is so thin in the periphery. Any attempt to do a vitrectomy is going to lead to problem. Your buckle with imbrication, if needed, can lead to a 20/50 vision with a single surgery. So to conclude, buckles have very few sight-threatening complications. Fewer follow-ups are required. It's long-term stability. I think this gives the surgeon the versatility to use the appropriate technique for appropriate pathology and customized to each patient rather than vitrectomy, silicone oil, membrane peeling, endolaser for each and every case. The single surgery success is very high. Please learn and teach your residents and your fellows how to do a good buckle. Thank you.
Thank you, ma'am. That was wonderful. I'd like to ask you, are there any particular cases, as you've shown, really difficult ones, where you will not use or not advocate using a tamponade in any particular situation? C3F8 or?
Yeah, so a lot of these high myope stickler syndrome, almost 100% of them will get glaucoma after you do a vitrectomy silicone oil. So I would always try to look for an opportunity to do a buccal rather than a non-vitrectomy case. All these cases, there's no tamponade. All these cases, this buccal with or without drainage.
Ma'am, what I meant was in a buccal, you will not use C3F8 or SF6, like for the traction. Like
All the cases that I showed you, there was no tamponade. Actually, there was no internal injection also. Most of them, we didn't even have to inject. If you're doing good buccal, you may not even need to inject something. Very rarely, if there's a lot of hypotonia after drainage, I might inject a ringer. Sometimes, if it's a spear HST, I might inject a bubble of air. But if it's a failing buccal, then I might inject C3F8. C3F8 or these gases, they can cause more shearing and they can develop new breaks. And then my population is all pediatrics. It will cause a lot of amblyopia because the gas will not go. They will not lie prone for such a long time. So really, there's very few cases where somebody might need a tamponade. Most of the cases, if your buccal height is good and you're able to do a good job, you don't have to inject anything.
Thank you, Dr. Subhadra. Does the panel have any questions or comments? Thank you, Dr. Subhadra.